Hi, I'm Liz Goodwin. I'm currently a research fellow at the Health Economics Group in Exeter, but before that I worked as a health economist in the NHS, and as part of that role I was involved in implementing a prioritisation process based on PBMA, and Hugh has asked me to share some key aspects of that experience with you, so I hope you find it interesting. So at the time I was working for an organisation called NHS Plymouth. This was a primary care trust, PCT, responsible for commissioning healthcare services in Plymouth for a population of over 250,000 people. And the Department of Health had just introduced its world-class commissioning assessments for PCTs. And the findings for NHS Plymouth were that we lacked what they referred to as a golden thread. So basically there was little alignment between our strategic objectives and our operational plans. So to address this, NHS Plymouth reviewed its annual planning process in 2009, and one outcome of this review was to adopt a PBMA process to set priorities for the financial year 2010 to 2011. Now, we decided to make some amendments to the standard PBMA process in order to tailor it specifically for NHS Plymouth. And the amended version is shown on the slide here. So we start on the left with the programme budget, which became known in NHS Plymouth as the Evidence Bank. And this was constructed around NHS Plymouth's existing structure of 9 health programme groups for service improvement. So these were things like acute care, mental health, learning disability and so on. The evidence included activity, cost, needs, performance, quality and user experience data using benchmarked figures wherever possible. And it was presented using a traffic light system. So green for we're doing well, amber for we've got a few problems here, and red for we really need to sort this out. Now, as we cross over the sort of dotted line here, we get to the amendments that we made to the process. And the idea here was to provide that golden thread to link strategic priorities and operational plans. So the first step here was to use the Evidence Bank to develop a set of strategic improvement priorities, which were agreed by the Professional Executive Committee. Then the lead manager for each health programme group was tasked with working up proposals for initiatives that would contribute to achieving these strategic improvement priorities. We established a set of screening criteria, these became known as the qualification criteria, to assess which of these initial proposals should go forward to be developed into full business cases. And it's at this point that we go over the other little dotted line back into the standard PBMA process. So for each of the initiatives that had successfully got through the kind of basic qualification criteria, a full business case was drawn up by the relevant health programme group lead. Each business case had to include projections of the expected impact on outcomes for service users and also of the net effect on the NHS Plymouth budget. The business cases were then assessed against a set of prioritisation criteria which were based on the values of NHS Plymouth as published in its strategic framework. So that's the process, but one of the most important things to consider if you want to introduce a process like this is just the sheer amount of practical work that is involved. So you need to set up and run a project management group, you've got to design forms for each stage of the process, you've got to nag people about deadlines, all that kind of thing. This is the donkey work. It's not exciting, it's not innovative, but it is absolutely essential and it takes considerable time and resources. You need to involve people with quite a wide variety of different skills, so health economics, finance, service redesign, analytical, clinical, project management, administrative, the list goes on. And no matter how carefully you plan, there's always going to be some unexpected event that lands on you from a great height and disrupts everything. And in our case, this was the announcement by the Strategic Health Authority that NHS Plymouth needed to save £20 million in the financial year 2010 to 2011. Now, at the time that all of this was going on, I was doing an MSc in Health Economics and Health Policy at the University of Birmingham, and the prioritisation process formed the basis for my dissertation. for which I undertook a formal evaluation of the implementation. So at this point, I'd like to acknowledge my supervisor at Birmingham, Emma Frew, who advised and supported me throughout the process. The evaluation involved me undertaking semi-structured qualitative interviews with 12 people who were involved in implementing the process. And so I'm going to spend the next few slides outlining some of the key findings from this evaluation. So in this next bit, where I refer to participants, I'm referring to the people that I interviewed for the evaluation. So, direct and indirect outcomes. A number of papers have been published that describe examples of PBMA being implemented, and their findings have been pretty mixed. Some have worked well and have achieved the desired objectives, others less so. And on the whole, our implementation was pretty successful. The prioritisation process succeeded in producing strategic priorities and operational service improvement priorities, and most participants felt that these were the right priorities. One of the key factors in this success was the way in which we'd amended the standard PBMA process to produce a two-stage process design, whereby strategic priorities were agreed prior to developing specific initiatives. Participants felt that this had created an unprecedented clarity, really, around the PCT's vision and objectives, and that it had created that golden thread as well, linking the strategic priorities and the operational work. But the prioritisation process also produced a number of indirect benefits. So two of the most important of these were it seemed to increase communication, understanding and sort of joined up thinking really between different parts of the organisation. And it also resulted in mental health, learning disability and public health services being viewed as priority areas, which was a bit of a first for an organisation that had previously been accused of focusing primarily on acute hospital-based services. So overall, participants expressed strong approval for the process. They felt that it provided a more systematic and open approach to resource allocation. And this really does link in to a recurring theme from the interviews, which is participants' disapproval of decibel rationing. Now, decibel rationing occurs where powerful individuals influence resource allocation decisions in order to reflect their own interests or pet projects. And published studies of the approaches taken by healthcare commissioning organisations in the absence of formal systematic processes for resource allocation show that decisions tend to be based on a combination of historical activity levels and decibel rationing. And NHS Plymouth was no exception to this. So the way this works is that typically the previous year's activity levels are adjusted using an estimate of projected changes in the demand for healthcare services. And then more fundamental shifts, so commissioning an entirely new service or decommissioning an existing one, for example, tend to be proposed by the most vocal members of the senior management team. This is not in itself necessarily a bad thing, but it rather depends on where those ideas for those fundamental shifts have come from. And is there evidence to suggest that this is a priority compared to all the other areas that we could focus our attention on? And is there evidence that the suggested initiative will achieve the desired outcome? That's not always the case. So one of the key reasons for participants' approval of the process was basically that it limited the influence of powerful individuals. So a bit of a sort of change of tack now. I'm going to move on to the more kind of health economics-y aspects of PBMA. So in terms of the sort of initiatives that might be proposed as part of a PBMA process, there's basically three types. So you can have disinvestments, that's services that can be scaled back or discontinued. There's service redesign initiatives. These aim to produce the same output for fewer resources. We refer to these as improving technical efficiency. And then there's service improvement initiatives. These aim to achieve better outcomes, but they require additional resources. And the whole idea of marginal analysis is that the technical efficiencies and the disinvestments can effectively pay for service improvement initiatives by releasing the resources that are required to implement them. Now, in NHS Plymouth, there was a very clear incentive for identifying disinvestments. It was the Strategic Health Authority's challenge for NHS Plymouth to save £20 million. But despite this, only one of the initiatives that went forward to the Professional Executive Committee represented a true disinvestment. The majority of the initiatives were service redesign ideas, which aimed to improve technical efficiency. And this isn't unusual. According to the accounts published in the literature, many applications of PBMA have struggled to identify areas for disinvestment. And the participants in my evaluation were very clear about the reason for this. They really firmly believed that disinvestment should not be considered until all opportunities for improving technical efficiency have been completely exhausted. However, when we added up all the predicted financial savings from all of the service redesign initiatives, plus the one disinvestment idea, this actually totalled less than the required £20 million worth of savings. So as a result, there were no resources available to fund any of the proposed initiatives that required a net investment. So that was a bit of a shame, but on a more sort of selfish note, perhaps, I don't know, for me personally, the biggest challenge around this whole area was in explaining the concept of marginal analysis and that whole idea of trading off between costs and savings. And this is actually quite serious, really, because marginal analysis that's the bit that really makes a difference. Because the idea is that by comparing the health benefits and the costs of specific changes in your existing expenditure, you can gradually shift that expenditure towards those areas that contribute the most to the objectives of the healthcare system. And it's here that the health economics component of the process really does sort of kick in. Now, I wouldn't worry too much about the detail of this next slide, but marginal analysis relies on some really key economic concepts, things like opportunity costs, the margin, this idea of trading off between different courses of action by looking at their respective costs and benefits. And the idea that in doing this, it kind of brings the financial and the health related implications of proposed changes together into a single equation, rather than viewing finance as a sort of separate entity that really only the accountants have to worry about. Now, all of this is second nature to economists. We use this sort of approach all the time, but it might not seem as obvious to clinicians or to managers who come from other backgrounds. And this suggests a need, which is reflected in the PBMA literature, for more education, really, around the key economic principles that underpin PBMA. And it is certainly something that, in retrospect, I should have paid much more attention to as the health economist for the PCT. Now, the last point really to come out of the evaluation is it is important to realise that the delivery of some initiatives will inevitably rely on external stakeholders changing their patterns of service delivery, and that decisions taken purely from the perspective of the commissioning organisation risk negative impacts on provider and other partner organisations. So another major theme of the interviews was that participants strongly felt that we needed to move from a healthcare commissioner perspective to a healthcare community perspective, incorporating Plymouth Hospitals NHS Trust, the NHS Plymouth provider arm, which is now called Live Well South West, and Plymouth City Council. Now, at this point, I thought it might be useful to highlight a couple of the factors that enable organisations to make a success of implementing PBMA, and a couple of barriers to success as well. So these are by no means exhaustive, but they are issues that were particularly apparent in our experience in Plymouth, and they're also referred to in the PBMA literature as well. So to start with the enabling factors, One of the key factors for us was designing a bespoke process, so tailoring the design of the process to the specific commissioning environment. I think that worked really well. But we also benefited greatly from having high-level champions. This really helped to sell the idea and to drive the implementation forward. And we were particularly lucky because our chief executive, John Richards, was an early adopter of PBMA back in the 1990s. And the book that is here, he actually co-authored this book on PBMA as well. So he was a very useful person to have in charge at that point in time. Moving over to the barriers to success, probably one of the biggest difficulties that we had was a lack of resources to support the process in terms of the amount of time that was available for the implementation, the number of staff and the proportion of their time that they could devote to the process, and also just the level of relevant skills and expertise within the organisation. And then we come to the problem of organisational instability. The disruption that is caused by reorganisations and the potential loss of key staff can deal a fatal blow, and unfortunately that is what happened in NHS Plymouth. Within a year of the process being completed, the UK government published the Health and Social Care Bill, which involved a major reorganisation of commissioning arrangements in the NHS in England. And this prompted several key staff, including me, to leave, taking our experience and our enthusiasm for the process with us. And hence the PBMA process broke down and was effectively lost. So this example of PBMA is over 10 years old now, and since then there have been major changes to commissioning arrangements in the NHS in England. Key among these are attempts to give clinicians, particularly GPs, a greater role in commissioning, as well as responsibilities for public health moving from the NHS to local authorities. And here in the far southwest, the organisational boundaries have changed. So we now have one clinical commissioning group for the whole of Devon. So that could make it trickier to implement a system-wide prioritisation process. Coordinating things across different local authorities and different providers and across such a wide geographical area would definitely make things much more complex. But the challenge facing commissioners basically remains the same. They're still charged with maximising the extent to which the aims of the local healthcare system are achieved within a fixed budget. So PBMA and other health economics-based approaches are surely as relevant as they ever were. And you can think of this in terms of the response to COVID-19. I'm amazed I've managed to get this far through a presentation without actually mentioning it. So a decibel rationing approach might urge you to throw more and more and more resources at COVID. But this would come at the expense of other health needs. For example, cancer diagnosis and treatment. So you can see how it actually be quite helpful to take a more technical PBMA-based approach to decision making in that particular example. So, in conclusion, I suppose the obvious question would be, should healthcare commissioners consider implementing a PBMA type approach to resource allocation? Well, as you might expect, my advice would be to weigh up the costs and benefits. I am an economist after all. Most likely is that it will work well in some environments and it will work less well in others. So you might want to consider the barriers and enablers that we looked at just now and the extent to which those apply in any given context, and think about the potential direct and indirect outcomes that could be achieved if the implementation is successful. But I think there's a fundamental problem with this question. And the reason for that is that it typically feels safer to stick with the status quo. As human beings, we tend to focus more on the risks of doing something different than we do on the risks of carrying on with the same old way of doing things. And this makes me feel inclined to turn this question around, just to look at it from a different angle. So I'm going to leave you with this question instead.